Well, good morning, good afternoon, and welcome and thank you all for joining us on today's virtual environmental ergonomics session. So this is now our sixth one in our fall and winter series. So they've been going terrific so far, and we're looking forward to this one. Today, we're going to be focusing on female physiology and especially on the impact of heat and hydration. So we're very excited to look at this under-researched area, and I think we can all agree that we absolutely need more research on women, on sex differences, and really not just assume that we can extrapolate or just transfer the bulk of the research to date, which has primarily been on men, over to women. So this is going to be really excellent in adding to our information on that. My name is Stephen Chung, and along with Tadej Debevich and Chris Tyler, we've been organizing this series. So we've been very happy and proud of this series so far and being able to add to the wall of fame of our speakers. We had 12 talks in the first series that we ran right after the pandemic started, and they were all on quite a wide variety of disciplines and everything from pollution to heat to isolation, altitude, cognitive functioning, and also in firefighting physiology, heat therapy. So really wide range of scope. And we've been continuing that in season 2 so far. We started with pre-cooling, and then we went to the heat of Tokyo. We had some excellent talks on the plans for heat management in Tokyo. Followed that up with altitude, then space, and then a real kind of thermal methodology look at sweat rate and skin temperature measurement. And I'll discuss later on about some of the upcoming talks that we have in our series. A reminder, if you have missed any of either series 1 or series 2, you can access them for free at ICEE2021.com. You'll see a tab up there for past events, or past talks. If you click that, you will see all of the current 17 talks that we have in the 2 series, along with most of them. If you see an underlined kind of a hyperlink on the bottom, that means that there are also student instructor guides to go with them. So you are more than welcome to use them for your classes. I know certainly many of these talks I have used for my own undergraduate and graduate class, and that's part of our kind of goal when we started setting up this series. And so that's an example of the worksheets. They're about a 1-page summary along with questions and kind of discussion points that instructors can be raising with the classes. So again, today we're going to be talking about heat and hydration in women. And so we're going to start off with Gabrielle Giersch, who is a postdoc at USARIEM near Boston in Natick, Massachusetts in the USA. And she will be talking about hydration considerations. She'll be followed up by Tori Stone, who is a postdoc at Yale, and she will be talking about cardiovascular considerations. So as always, I invite you to interact with us using the Q&A tool. You can type in questions from there. After each talk, I will kind of take some of the questions and ask them and moderate a discussion. And then if there are additional questions, the speakers can also be interacting with that Q&A tool. So please use that to communicate any questions to us. So with that, I am going to stop sharing and hand over the stage to Dr. Giersch.
Thank you very much, Stephen. Just to quick check, everyone can see my screen? Great, thank you. So thank you for the introduction, Stephen. Very excited to be giving this presentation today. I am going to start us off, as you mentioned, talking about specifically some hydration considerations for women and kind of mainly where our research is lacking and where we need to know more. Just a short disclaimer, the opinions or assertions contained herein are the private views of myself and are not to be construed as official or reflecting the views of the United States Army or the U.S. Department of Defense. And with that, we will get started. So as environmental physiologists, we all know how important hydration is for our overall physiological functioning. It helps us to stay healthy and well, from the cardiovascular to our renal to our entire body systems. It also helps us stay safe when we're talking about environmental extremes, because we know that being dehydrated puts us at an increased risk for developing exertional heat stroke and other exertional heat illnesses, but it also increases the severity of acute mountain sickness and our risk for developing acute mountain sickness when we're at altitude. We need to be appropriately hydrated to perform optimally. And there has been some debate on this, but largely, especially at greater degrees of body mass loss and dehydration, we're pretty well certain that being dehydrated impairs our endurance performance, most certainly, muscular and anaerobic performance at higher degrees of body mass loss, and our cognitive performance. So if we're not able to perform optimally, that's also impairing our safety, especially when we're talking about injury risk. And it impairs our mood. So we need to ensure that we are appropriately hydrated to stay healthy and well when we're in general and in environmental extremes and undergoing environmental stress, and also so that we can perform optimally. And as environmental physiologists, this is really important for us because we use our data and our publications to make recommendations for our physically active population. And where this ties back into today's talk is we know that women are underrepresented, as Stephen mentioned. Sports science isn't immune to this trend. Across physiological research, we know that women aren't studied as often as men due to a few different considerations, including sex hormones and cost and inconvenience. And not to say that those are necessarily the best reasons to not include women, but we know that that's the case, that women are largely underrepresented in sports science research, and hydration and thermal physiology aren't immune to this trend in any way, shape, or form. And this is important because here in the US, we have governing bodies like the American College of Sports Medicine and the National Athletic Trainers Association, which make recommendations and produce position statements that synthesize the data that we have published to say, here's how you can replace the fluid that you lost during exercise. Here's how to prevent yourself from developing exertional heat illnesses. And if the data has been largely published in young college-aged healthy men, that's who the recommendations are for. So we don't have enough data out there for these governing bodies to make recommendations for our women. And when the data does include women, especially of the 4 that I've mentioned here, it hasn't been sex disaggregated. So it's really hard when we only have 10 subjects and 2 of them are women and all of the data has been analyzed together without any kind of sex disaggregation for us to say, hey, this is true for women. So all of the recommendations that I'm showing here and the other recommendations that are out there are largely based on data collected in men. So they're recommendations for a young, healthy male population, leaving our women out in the cold, for lack of a better term, because we don't have the data to make the recommendations to keep them healthy and safe and performing optimally. So it's important for us to study women because women make up a significant proportion of our physically active population. Of the Tokyo now 2021 Olympics, 49% of all the athletes that are going to be participating in the heat are women. Across the United States, for almost 10% and over 40%, depending on the occupation, are physically active as laborers. So going from farming to warehouse work. 16% of the US military is women, ranging from 9% in the United States Marine Corps to over 20% in the United States Air Force. And we can't say, as Stephen mentioned previously, that men and women have identical responses. And even if the outcome's the same for men and women, as some research shows, it doesn't mean that the mechanisms through which we got to that outcome are the same. So we can't use the data that we have and say women are exactly the same as men, because there are a lot of things that make women women that would lead us to have different responses to environmental, exercise, and hydration stressors. And we know that environmental stress also impacts our hydration status, especially when we're performing physical activity. They impact a wide array of our physiological functioning, which is, as we mentioned at the very beginning, is important for hydration to keep us safe and healthy. And for the purposes of this presentation, I focused mainly on heat, cold, and high altitude because those are the most pervasive and the most common that our physically active population would experience. But we know that these environments can add a further level of stress when it comes to hydration, where in the heat, especially when we're exercising, we have an increased sweat rate. And that increased sweat rate does lead to a decrease in plasma volume. And it's through some equilibration. We don't sweat from our plasma volume, just to make that clear. But our body water compartments do equilibrate when one compartment is lost. And that ultimately leads to a decrease in blood volume and plasma volume. In the cold, we have vasoconstriction, cutaneous vasoconstriction in our skin and in our periphery, which increases our venous return to the heart. And that venous return stretches our atria. And that atrial stretching leads to an increase in the synthesis of AMP, which increases our urine output, subsequently decreasing our plasma volume. High altitude is kind of a twofer when it comes to hydration, where we increase our ventilation, and that increase in ventilation leads to an increase in bicarbonate buildup in the blood, which decreases our blood pH, increasing our urine output so we can kind of pee off those excess hydrogen ions, leading to a decrease in plasma volume. And that increase in ventilation leads us to evaporate more from our respiratory tract into the cool, dry air, leading to more respiratory fluid loss through the respiratory system and hydration. And where this can get interesting when we bring in sex is there are some sex differences that we know exist. Across menstrual cycle, between men and women with oral contraceptive users, there's enough research out there that we can say there are differences between men and women in body size and in sweat rate and in skin blood flow. We know that those differences are there, but we haven't specifically investigated how those differences may interact with our environments in the terms of hydration status. So possible interactions with sex here is we know that there's a difference in onset of sweating threshold between men and women at a given body temperature. We also know that men sweat more than women. And we know that body temperature increases in the mid-luteal phase of the menstrual cycle when compared to the early and late follicular phases, which we will talk about more. We'll go into detail on the menstrual cycle. In the cold, there are physical differences between men and women. Women are on average smaller than men and have more subcutaneous body fat, which serves as an insulative factor. And there's varying responses in that vasoconstriction response to cold, where women vasoconstrict more severely and are actually more at risk for developing Raynaud's phenomenon. At high altitude, there have been observed differences in diaphragmatic fatigue in hypoxic conditions. So our diaphragm in women, the diaphragm fatigues more severely in women and at an earlier time point than men. So women may not hyperventilate as much. And we know that dehydration increases our risk and severity of acute mountain sickness, and women already have a more severe response to AMS than men. So these are just some very high level points of the more research that we need in these areas so that we can make appropriate recommendations when we have women in heat, cold, and high altitude that are performing physical activity. We need to make sure that they're appropriately hydrated so they're staying safe and that they're performing optimally. So these are kind of areas where there might be an interaction effect between sex and environment and physical activity that may make differences between men and women and how they respond. So from a 30,000 foot view, what we have is our primary mechanisms regulating our body fluid balance. So we know that when we become dehydrated, we've lost body water. And that body water loss leads to an increase in our plasma osmolality, which increases our arginine vasopressin synthesis, which causes us to retain more fluid at the level of the kidney through the aquaporin receptors. That body water loss is also due to plasma volume. And so we've lost blood volume, decreasing our blood pressure, which simultaneously stimulates AVP release and aldosterone production, which helps us to retain more water through our sodium channels. So this is just, we're gonna integrate some of our sex hormones with this figure itself, but just to kind of give a background of how our body fluid balance and the mechanisms associated with body fluid regulation, just to give some context. Where this gets important is we're not just, as Stephen mentioned, we're not just talking about sex differences. We aren't just talking about men versus women. We need to continue to do research where we're comparing the sexes, but we also need to make comparisons within women, because women may have drastically different responses to varying stimuli depending on their menstrual cycle phase. And so we have this figure here, which shows our cycling female sex hormones across the menstrual cycle. And so what we have is the follicular phase going from day 0 to around day 14 for ovulation. This is a quote unquote textbook menstrual cycle, if you will. And the luteal phase goes from ovulation, or day 14, to day 28. And so what we see is we have this early follicular phase, or the red bar that I've added here, which is the area where we menstruate. That's where all of our sex hormones are characteristically low. We have low estrogen, low progesterone, almost no LH, almost no FSH. And so that is oftentimes used as the menstrual cycle phase because, one, it's really easy to test women in that phase because you say, hey, you're menstruating, you started your period, let's get you in for testing. It's really convenient in that sense, but it's also missing out on all of that hormonal variability. And it's still really important to test women in this phase because there may be other things that are impacting a possible sex difference here, whether it's body size, whether it's some other factor behaviorally that may be impacting this sex difference, but we're missing out on that hormonal variability. So in the late follicular phase, we have the peaked estrogen concentration, and then in the mid-luteal phase, we have our progesterone peak and high estrogen as well. And this gets important because we know that estrogen and progesterone interact with our body fluid regulatory hormones. So if we go back to that figure from that 30,000 foot view of our primary methods of body fluid balance, we know that estrogen has a positive relationship with AVP and actually decreases the osmotic threshold for AVP release. So for example, if we were becoming progressively more dehydrated, women in the early follicular phase, or in theory, men may start to release AVP, or arginine vasopressin, at 300 milliosmoles per kilogram. But in women where estrogen is high, they may start to release AVP at 295 milliosmoles. So they release it at an earlier time point in progressive dehydration due to increases in estrogen concentration. And we know that that's the case, that estrogen actually alters our osmotic threshold for AVP release. And then we also know that progesterone has a very positive, strong relationship with aldosterone. And the mechanisms through which progesterone impacts our body fluid balance aren't as clear yet as estrogen, but we do know that it has that effect and that it has that positive relationship. So depending on menstrual cycle phase, women may have a very different response to a dehydrating stimulus or an environmental stimulus than they would in the early follicular phase, the mid-luteal phase and the early follicular phase, or even the late follicular phase. So that hormonal variability is really important to capture, and we don't have enough data yet to really understand how that hormonal variability may impact outcomes associated with these stimulus. Another area, just to throw another wrench into things when we're talking about women, is it's not only important to compare based on menstrual phase, it's also important to understand that women take oral contraceptives or use contraceptive methods to help to regulate this cycle. And so what we're seeing here is actually a monophasic oral contraceptive on the screen. So where we have 0 days to 21 days, and you get the same concentration of synthetic estrogen and progesterone every day for 21 days. And then starting at 21 days, you have a cessation of the synthetic hormones, or placebo pills or sugar pills, which is called the kind of placebo phase of oral contraceptive use. And so from days 21 to days 28, you have what's called a withdrawal bleed, which people oftentimes compare to menstruation, but they're not exactly the same thing. But women in the placebo pill phase may have a very different response than women in the active pill phase. And that placebo pill phase has often also been used when women are included in research with oral contraceptives to say, hey, you're in the placebo pill phase, you're not getting synthetic exogenous hormones, let's throw you in testing now. But we're missing out on that added variability that the exogenous synthetic hormones may be having on our body fluid balance. And they do. Some of the work actually from Nina Stockenfeld's lab in the 2000s has shown that oral contraceptive use does impact our body fluid regulation in a similar way than as it would in the menstrual cycle, even though they're synthetic hormones. So just to summarize kind of what we've gone over with all of those figures that I just showed, just to put it in words, we know that vasopressin and estrogen concentration are highly related, and that estrogen actually alters the osmotic threshold for AVP by lowering it so that we produce AVP at an earlier time point than we ordinarily would without a high estrogen concentration. Progesterone and aldosterone are very positively correlated, although the mechanisms through which progesterone has that effect aren't clear yet. Women have lower plasma volume and total body water in absolute terms, and that's likely due to body size. So that's not necessarily regulated by sex hormones, but that's something to consider when we're making these recommendations to say, when we're talking about fluid needs and recovery following exercise, we need to take into account that women have lower total body water and plasma volume so that we're not putting them at an increased risk for developing hyponatremia by having them overconsume fluids. So this is a very good schematic figure, actually produced by Nina Stockenfeld in one of her very comprehensive reviews on sex hormones and fluid regulation, that just shows the integrative nature of estrogen and progesterone. So estrogen and progesterone aren't just related to reproduction for women. They're very integrative hormones. They affect all of our physiology. And so here you can see all of the different components, whether it's thirst and sodium appetite, kidneys, cardiovascular control, and blood pressure, that estrogen and progesterone on this figure denoted by E2 for estrogen and P4 for progesterone, how they can impact all of these different areas and really kind of get their, for lack of a better term, get their hands in and really play an important role in maintaining our body fluid balance and retaining body water, especially when we're talking about dehydrating stimuli. So it's important that we're continuing to include women. I think that we're on an appropriate trend of having more research that does include women, but it's still really important to elucidate some more of these mechanisms and determine that how their outcomes may be different so that we can make appropriate recommendations. So I know that these usually end with some practical recommendations, but as I've probably beaten a dead horse with, we don't have the data to make those recommendations or practical applications here. But what we do have is a lot of opportunity for future research. So I know that there are a lot of researchers on this seminar right now, and there's a wide open opportunity here to investigate some of these questions that are still outstanding. So we know that some mechanisms contributing to dehydration are affected by sex hormones, but we don't necessarily know how they relate to effect of outcomes and how women may respond differently compared to themselves and compared to men when we're talking about a dehydrating stimulus. Risk for hyponatremia. Women have been previously thought to be at an increased risk for hyponatremia. We don't necessarily have the data to support that. And we don't know why they would be at an increased risk for hyponatremia. Method of dehydration, there are a ton of different stimuli that we can use to dehydrate people, whether those are passive with diuretic fluid restrictions, sauna, or exercise and exercise heat stress. And there are varying degrees to which you can become dehydrated, which is the size of that stimulus. Some recent work that we've recently put out last year showed that a 24-hour fluid restriction only elicited a 1% body mass loss. And while that was really not fun for our research participants, they only got 1% dehydrated, and there was no apparent impact of sex or menstrual cycle phase on the level of dehydration that they reached, even though there were some mechanistic and kind of biomarker effects there. We don't know if women or men or one or the other or women versus themselves are more susceptible to dehydration and how these mechanisms may interact with our level of dehydration achieved in these different phases and with the size of the stimulus. We have absolutely no idea how hormonal status and dehydration may impact performance. So we have a lot of data that shows, especially endurance performance is impaired by dehydration, but we don't know anything about how women's performance may be affected. And that's important, especially when we're talking about our athletic population and trying to keep them performing optimally, especially in these environmental stressors. So we need to continue to compare sexes and investigate sex differences and determine if there are differences between men and women. But we also need to include these within women comparisons. So comparing based on menstrual phase, those oral contraceptive phases, not normally menstruating versus oral contraceptive users, and also start to include some of these other forms of hormonal contraception, which have very, very limited sports medicine research, like the implantable bar or hormonal IUD. And so with that summary and conclusions, we know some mechanisms are affected by sex hormones. There's a lot that we don't know, and we still need more research. And with that, I will open up the floor to answer any questions.
Well, thank you so much for that, Dr. Giersch. That was excellent in terms of outlining, again, so much of what we don't know. And again, I'm going to be moderating questions, so please use the Q&A tool to submit any that you have. And I'm going to put you on the spot. and probably it's an impossible question, but I absolutely agree that there is so much more work that needs to be done. But the fact is, right now, as you pointed out, there are women in the military. There's 49% women athletes planned roughly for Tokyo and et cetera. So let's just take the military as an example, and you're at a US Army research lab. So can you give an example of kind of the current hydration policies for soldiers in general? And if a commander came to you and says, how do I modify this for women? What would you tell them kind of right now, barring that, we don't know so much?
That's a great question, Stephen. And I think the current hydration recommendations are largely to try to replace what you've lost. There are some applications that try to help you figure out how much water to actually take out on a mission with you and how much water they should consume based on wet bulb globe temperature, based on wet bulb globe temperature, how hard they're working, using some kind of accelerometry data in that as well. I would say that also hasn't been validated in a female population, but is just making sure they have enough water with them is also very important, especially when they're out on mission. But if someone came to me and said, how can I make this specific to women, what I would fall back on is to say, especially if we're having someone exercise, and ordinarily, like, where I'm more specific to heat. So exercising in the heat, I would say knowing sweat rate is very important, because you want to make sure that you're replacing what you've lost due to exercise and not overshooting. We want to prevent developing hyponatremia. So really knowing that sweat rate is incredibly important, and it's a really easy calculation to figure out, as we all know. So that's what I would say. I would probably be a little bit more specific with it and say it's really important to know each woman's sweat rate and have them try to kind of self-monitor, or have their commander try to monitor how much fluid that they're consuming to ensure they're replacing appropriately. But that's a great question.
Yeah, it's always a challenge, right? You can only fall back so much on, we need more research, because
Absolutely.
there are people out there now, right, that need help, not necessarily waiting, for, whatever, 5 years before we can update the policy.
Oh, absolutely. That's an excellent point. Is we have to do the best we can with what we have, because we do have a significant proportion of women, like I said, who are currently in physically active populations, and we need to do something for them. And research is only one step, but we need to make sure that we're taking what we know from a physiological perspective to ensure that we're doing the best that we can for them with what we know now.
Okay, and I have a good complex question from my own PhD student, Kate, that I think might be better for kind of a panel talk after Tori also speaks. But I guess we'll close out kind of this first part by asking another question. Are there known differences in thirst perception across kind of menstrual cycle and also potentially with hormonal contraceptive use? Because, obviously one is knowing your sweat, but, if you're not thinking you're thirsty, not drinking. So can you shed any light on the idea of thirst perception?
Yeah. So actually, interestingly, and I probably should have mentioned this, but I was thinking more inherent mechanistically, estrogen has that similar effect on thirst as it does on AVP. So when we have higher estrogen concentrations, our actually osmotic threshold for thirst shifts as well to a similar degree. So I haven't seen any specific data that specifically tried to target thirst perception all the way across the menstrual cycle within each phase to see if that actually has a marked decrease, or actually I would say increase, in how thirsty you feel in a given phase. But I would imagine that it probably is there. And again, it's another opportunity for future research. But we know from a mechanistic perspective, the signaling for thirst is affected by sex hormones. But that's a great question.
Okay, so one other question in terms of that's relevant for hydration for this talk is which parameters to check for hydration status in women, for example, in elite rowers? Would you consider USG by itself to be enough, hematocrit? And also, what recommendations do you have to evaluate high or low kind of values in that parameter? So that's a question from Sebastian Buitrago. I hope I'm kind of asking that question properly.
Yeah, that's a great question. I would say as many as you can is always better. I don't know that any one in isolation would really be enough. And we don't have standardized target values, just to go ahead and say that, for female population. And we don't really have any indication that urine values would necessarily be different specifically to USG. So shooting for under 1.020 would still probably be a good target until we get data that says otherwise, that those standards should be different for women. But I would say if you could do urine color, USG, and body mass changes, and then even throw in their thirst perception in there, that would probably be a pretty good indication. But again, we don't have the data. That's just what I would say based on what we have. That would be a good kind of starting point for assessing hydration status in a group of really elite, physically active female rowers.
Yeah, I think I would certainly agree with that. The more, the better. If you can get daily USG and daily body weight kind of pre-post, but also maybe supplemented with occasional hydration, or sorry, with hematocrit measures too. I think that would be the best rather than just trying to rely on one single parameter by itself.
Yeah, one really can't carry all that weight. And I think we would say that that's even true for men. And plasma osmolality is probably one of the best that we have, but that's also invasive. And to try to do that every day would get to be quite daunting. So using urine measures in combination with body weight, thirst, and then occasional blood markers would definitely be ideal versus trying to have one of the urine markers kind of pull the weight for the entire team.
All right. Well, thank you for that. That was an excellent first talk. And I'm going to ask you to unshare your screen, and I'll introduce Dr. Tori Stone while she starts sharing her screen. And Dr. Stone is a postdoc at Yale, and she's going to be talking about the cardiovascular issues and exercise in the heat.
Okay. I always like presenting after Gabe. She really sets the stage. She does an excellent job. So I'm happy to be here again. I'm Tori Stone. I'm a postdoctoral associate at the John V. Pierce Laboratory and Yale School of Medicine in Dr. Nina Stackenfeld's lab. And sorry. All right, here we go. I know it's not very customary to do acknowledgements first, but I did want to acknowledge Jonathan Wingo. So before I came to Pierce, I spent four and a half years at the University of Alabama in his lab. This is where I collected the majority of the data, all of the data that you're going to see today. So I wanted to acknowledge him outright, and the individuals that helped me out in his lab, and others that weren't in his lab and they were just grad students. So I'll start with a very basic graph and a very basic statement. Cardiovascular strain is greater as thermal strain increases during exercise in the heat. And that's the graph that you're looking at. So make sure everyone can see my mouse here. Okay, so what you're looking at along the x-axis is rectal temperature. So that's our index 4 temperature. And then our y-axis is heart rate in beats per minute. And you can see that these two variables, they have a pretty strong relationship, okay? So as core temperature is increasing, you see a very matched increase in heart rate, okay? So that drives my point that as core temperature increases, especially during exercise heat stress, you're seeing greater cardiovascular strain. Few explanations for this. So some mechanisms to kind of set the stage again. Hyperthermia leads to cardiovascular impairments, and I've listed a few. They happen in a number of ways. So there is a greater competition between muscle and skin blood flow. With greater skin temperature, you see an increase in skin blood flow. This is a cooling mechanism. High core temperature increases, I have intrinsic heart rate. So this is a direct increase or a direct effect on heart rate. And then you also see increased sympathetic activity. In both of those, you'll see an increase in heart rate, so decreased ventricular filling time, and this leads to decreased stroke volume. So those are, again, these cardiovascular impairments that I'm talking about. You also see hyperthermia, or this increase in core temperature. It leads to increased sweating, which leads to dehydration, and Gabe talked a little bit about that, but this also leads to some of these similar cardiovascular impairments. So today, I'll be focusing a lot on the, at least with the first study I'm going to talk about, the direct effect of core temperature on intrinsic heart rate. Now that I've sort of talked a little bit about the mechanisms, it's easy to look back at this same graph that I showed before and say, okay, well, this increase in core temperature is definitely driving this increase in heart rate. But this is just a relationship, right? This is where it gets a little bit tricky, because this increase in heart rate, especially during prolonged exercise, it's going to happen regardless of a substantial increase in core temperature, especially during the experimental conditions, which I've now listed for you. So you're looking at prolonged exercise. Yes, it's in the heat. It's performed at a constant rate, and it's at a moderate intensity, so 60% of VO2 max. So what you would expect to see during this type of exercise is a physiological steady state. However, you don't really see this, especially after about 10 minutes. You begin to see this progressive increase in heart rate and a decrease in stroke volume, while cardiac output is generally maintained at the same level. This is called the cardiovascular drift phenomenon, and this is what I did a lot of my work on with Jonathan at Alabama. And what you're looking at here, so you're looking at time, okay, so from 15 to 45 minutes, and then your y-axis is the change, a percent change from 15 minutes for heart rate as well as stroke volume. So you're seeing that after about 15 minutes, okay, so we're assuming that a steady state was established, but now you're seeing this progressive change in heart rate. So by 45 minutes, it's at 9% increase. And then at 45 minutes for stroke volume, you've seen an 11% decrease. And even though cardiac output is, like I said, generally maintained, you see this decrement that's occurring at the same time, a proportional decrement in VO2 max, which we could also call exercise performance. If we assume that this magnitude of drift and the associated decrement in VO2 max occurred at a core temperature of 38 degrees Celsius, a very important point is, as core temperature increases, you're going to see that magnitude of both increase. So you see a greater magnitude of drift at these higher core temperatures. A variety of factors have been studied related to cardiovascular drift and the relationship with VO2 max, but the most influential factors where you'll see the greatest magnitudes of cardiovascular drift and decrements in VO2 max is going to be hyperthermia. And that was a lengthy explanation to lead me to this point right here. Is that's a primary reason why women have been excluded from almost all of the studies investigating this relationship. So I focused a lot of my work on this relationship, and I addressed some of these primary factors, like why they're being excluded. And the first one is the menstrual cycle phase. This is the one that is very reoccurring. You see it over and over again. We excluded women from this study because of that increase in core temperature that Gabe was talking about in the luteal phase. So we address that. Like Gabe had said, we see this increase in core temperature across the menstrual cycle. So it's about 0.5 degrees Celsius, which is pretty significant, higher in the luteal phase versus the follicular phase. So our question was, could this difference in core temperature or difference in core temperature of that magnitude modulate the increase in heart rate that's expected during cardiovascular drift? Because if it's driving, like if hyperthermia is driving this increase in heart rate during the luteal phase, we would expect to see greater magnitudes of drift and associated decrements in VO2 max during that phase. My experimental methods, bear with me, they are pretty standard across the board. So with the next two studies that I'll talk about, we use the same method. So you won't see this again, but I can always go back to this slide because it takes people a minute to look at the methods and realize, yes, I get what they did. So the first day was just a control day. We did the control day because we needed to establish a baseline VO2 max so that we could prescribe exercise at 60%, so a relative intensity. The next two are the other conditions. We had to do a 15-minute trial and a 45-minute trial in both phases of the menstrual cycle, so in the follicular phase and in the luteal phase. We'll start with the 15-minute trial. The 15-minute trial, so they exercised for 15 minutes. This was in the heat at 60% of their VO2 max, and immediately performed a graded exercise test to volitional exhaustion so that we could assess VO2 max. The 15-minute trials are essential to this design because it's important because we needed to show that VO2 max is the same as the control VO2 max before the onset of drift, okay? So the next one we did was a 45-minute trial. So they exercised for 45 minutes in the heat. We established drift from 15 to 45 minutes. So we measured heart rate and stroke volume at 15 minutes, and we measured both of them again at 45 minutes. And just like the 15-minute trial, they performed a graded exercise test to assess VO2 max. We'll look at the results for core temperature and heart rate first. Well, it's important to understand that there was, that textbook difference in core temperature between the two phases. So core temperature was higher at rest during the luteal phase compared to the follicular phase. And you saw this sort of maintained over the course of the 45 minutes of exercise, and as well at max, okay? So here you're seeing luteal phase, like there really isn't a difference between the change in core temperature. So what you're looking at here, these asterisks, this would be like an effect over time. So of course, core temperature increased over time, but there wasn't an interaction here, which was an important finding, that this difference in core temperature was maintained. It didn't increase, or it wasn't greater in the luteal phase. Now, we would expect, so I was wrong about the hypothesis, right? I thought heart rate would be different, but it really wasn't. There was a significant drift in heart rate, of course, over time, but absolute heart rate was basically the same between phases. Okay, so this difference in core temperature it wasn't great enough to impact heart rate, at least absolute heart rate, in terms that would impact stroke volume, which we'll get to here in a minute. So the graph you're looking at here, again, you're looking at the change from 15 minutes, it's a percent change. So from 15 to 45 minutes, and it's for our primary outcome variables. So that's heart rate and stroke volume. So these would be for cardiovascular drift. And then we have VO2 max to establish that relationship between cardiovascular drift and the change in VO2 max. So you're seeing no change or no difference between phases for the change in heart rate. It's almost exactly the same. This was different though, right? Because you know, we didn't expect this, especially because there wasn't a difference in the change in VO2 max between phases, because generally the change in stroke volume is going to at least be somewhat of a predictor for the change in VO2 max. So we did see a significant difference. There was a greater drop in stroke volume in the luteal phase compared to the follicular phase. So that definitely warranted a closer look. And when we looked, this was basically the only difference, the really standout difference that we did see between phases. And what you're looking at on top here, so the red is the follicular and the blue is the luteal. Stroke volume are the dots, and then VO2 max, the change in VO2 max that we're trying to explain, are the upside down triangles. So what we're seeing for absolute level of stroke volume, so not the change, absolute level of stroke volume, so these levels were higher at 15 minutes in the luteal phase compared to the follicular phase. These differences weren't significant, but they do help us explain the results that we're looking at here, because you're seeing that over time, stroke volume dropped to a similar absolute level between phases, which is important because this means that the absolute level of stroke volume going into that VO2 max test was really similar. You can see the, oh good, I put it there. You can see the difference. So 60 mLs per beat in the follicular phase and then 59 in the luteal. So it's essentially almost exactly the same. And if absolute stroke volume is the same between phases, we wouldn't expect there to be these differences in the change in VO2 max either. So that was an interesting finding. I have one more graph to show from that study, and it's going to help me kind of make my point for my next factor that I wanted to address, which is fitness level. So what you're looking at here, you're looking at the individual slopes for each individual that participated in this study. So at the top, you're looking at stroke volume. Okay, so luteal phase over here, follicular phase over here. The top two graphs are stroke volume and the bottom two graphs are VO2 max. It doesn't matter which one you look at. I just want you to look at the slopes. Okay, so what's going on? My question was, what's going on? Why are these individuals, so let's look at like a really steep slope. So why is this individual experiencing so much drift? And definitely, why are they experiencing such a big increase in or decrease in VO2 max compared to someone down here? Okay, so I mean, there is some big differences. There are some big differences in the slopes that we're looking at here. And the answer lies with, okay, is there an effect of fitness level, or rather, is there an effect of metabolic heat production? I actually want to go back. Yeah, so these individuals, I'll just kind of give it away. These individuals are of higher fitness. They have a higher fitness level. So for, hold on. So at a given, like I said, these individuals, they're exercising, or these women were exercising at 60% of their VO2 max. So at a given relative metabolic intensity, so again, in this case, it was 60% of VO2 max, the individuals with higher fitness levels, they're going to be working at a higher absolute intensity to achieve that, that relative, that 60% intensity compared to the lower fit individuals. And this is going to increase hyperthermia, which is, like I said, that primary factor that's going to impact the magnitude of cardiovascular drift and associated decrement in VO2 max. So this certainly is something that I wanted to look at a little bit closer. And although we included women with different fitness levels in this study, and that's fine. That's fine if there are different levels of metabolic heat production in a repeated measures design. But this becomes very problematic if you are to use an independent, you make independent comparisons between two different groups, especially when they aren't matched for fitness level. And I'll illustrate that point now. Okay, so what we did, we took two groups of women, again, trying to close this gap in the literature a little bit. So we compared two groups of women. They were high and low fitness. That's how we characterize them. So baseline VO2 max for the high fit women, like around 50 or 49. And then our lower fit women, pretty low relative VO2 max. Okay, so around 35. So big difference. They perform the same, I want to go back, sorry. They performed the same methods to assess cardiovascular drift that we had used in the previous study. So we used the 60% VO2 max, and our hypothesis was that the high fit individuals, they'd be working at a greater metabolic heat production. This would impact hypothermia, so they'd experience greater levels of hyperthermia, and this would lead to greater magnitudes of drift in those decrements in VO2 max compared to the low fit individuals. However, we added a condition where we controlled the level of metabolic heat production. So we prescribed exercise using a fixed level of metabolic heat production, and this level was at 500 watts of metabolic heat production. I put a lot of descriptive statistics up here just to make a point that it is important. We had to control for body size and body surface area, because these things are going to become very important if you're prescribing exercise with metabolic heat production. So when we looked at, what did I start with here? So the differences in hyperthermia and metabolic heat production. So we started with this graph right here. So we're looking at 60% VO2 max. And what you're seeing is core temperature increased quite a bit more in the high fit individuals. Okay, so we're expressing the change in core temperature from rest over time. And like I said, these individuals, there was like the high fit individuals, they're working at a 30% higher level of metabolic heat production, okay? Regardless of, you know, being at the same relative intensity, okay? They're of a higher fitness level, so they're gonna have to work at a greater work rate in order to achieve that prescribed relative intensity, okay? And you're seeing the difference in hyperthermia here. However, when we prescribed exercise using a fixed level of metabolic heat production, again, we use 500 watts, these differences, they disappear. And for the sake of time, now I'm regretting it, but I didn't put the cardiovascular drift data up here because I wanted to get to my next point or my next study, but our hypothesis held true. So these differences that you're seeing in hyperthermia, they explain the results for cardiovascular drift. So at 60%, the high fit individuals that are experiencing this greater level of hyperthermia, they had greater magnitudes of drift as well as a greater decrement in VO2 max. When we prescribed exercise at this fixed level of metabolic heat production, there were no differences in hyperthermia. So you guessed it, there were no differences in cardiovascular drift and those decrements in VO2 max. So really cool findings. That was a tough study to do, but got a lot of help on it. So I wanted to make the point before moving forward that although I would love to make recommendations, like, yes, so maybe this is telling us that men and women could be included in the same study, because look at these results for hypothermia, and there were no differences in cardiovascular responses when exercise was, you know, fixed at a heat production. However, this heat production is pretty high. So if you did want to include men and women, my recommendation would be certainly control for body size and body surface area, and perhaps prescribe it at a lower metabolic heat production. This is an absolute level, lower than 500 watts, because we do see sex differences in pseudomotor function at high levels of metabolic heat production, where women, they reach a plateau in sweating. So this is a perfect graph to illustrate it. So what you're looking at here is the change or local sweat rate, and it's expressed as a function of the change in mean body temperature. So what you're seeing at this high level of metabolic heat production is women, their sweat rate, it plateaus. For men, you see sweat rate continue to increase with the change in body temperature. So if you're continuing to sweat, what happens? You sort of, you prevent this extreme change in body temperature. But for the women that reach this pseudomotor threshold or this plateau in sweating, what happens? If they stop sweating, Sweating is a primary cooling mechanism, the most important, that we rely on during exercise anyway. If they're not, what do I want to say? If this cooling mechanism is no longer working, I guess is a decent way to say it. If this cooling mechanism is no longer working the way that it should, then what you see is an increased change in, or an increased body temperature. And it's pretty significant, especially when you compare it to the men that continue to sweat, so they could kind of at least not experience as great a change in core temperature as the women. This is another way to look at it. So, or at least drive home my point that, you know, these differences in sweating are really going to lead to differences in core temperature, or core temperature over time. So during exercise, you're seeing this this big difference, especially towards the end of exercise, when, like I said, this plateau sort of started to at least present. So you see that women, okay, we're sort of matched, and then at the end, or towards the end, where they probably reached this this sweating plateau, you're seeing core temperature really start to rise in women, and men it sort of levels off. Again, hyperthermia is one of the most influential factors that's going to affect the magnitude of drift, so these cardiovascular responses. And you did see differences, although they weren't statistically significant. And I need to look closer at this data. So the asterisks that you're looking at here, those are merely telling you that there was a significant change over time. So the change from 15 to 45 minutes in heart rate and stroke volume and VO2 max, it was a significant change, but there were no differences in these changes between men and women, although it looks incredibly different. So we probably could look at these data a different way. I looked at the absolute values. Like I said, that data isn't published yet, so I mean, we'll certainly look at it a little bit closer, because those are pretty big differences. It would be almost unethical to say that you know, they weren't statistically significant, so there are no differences. I mean, clearly there are differences that should be considered, at least for experimental design purposes, if not physiological. We did, like I said, what you're looking at here, these are the absolute cardiovascular responses, and these are at 45 minutes. So you're seeing big differences. And I didn't run statistics on these yet, but you're seeing big differences in heart rate. So because women are experiencing this higher core temperature, heart rate is way higher. Okay, so by 45 minutes, 175, 153 in men. It's a big difference because women are experiencing this higher heart rate. This is decreasing ventricular filling time, and this is thereby reducing stroke volume. And this reduction in stroke volume, like I said, that's going to predict kind of what happens to VO2 max or exercise performance along the way. And then I also put up mean arterial pressure. So mean arterial pressure has fallen, or is lower in the women compared to the men. So the biggest one that stands out to me, obviously, the two variables that I was looking at, so heart rate and stroke volume. Okay, I meant to put conclusions on that last slide. Sorry about that, but I think I already made a few of my conclusions and recommendations, like I had said before. So, you know, fitness level does need to be factored in, certainly, because of the differences in metabolic heat production. And this is fine, maybe less of a factor when you're using a repeated measures design. However, if you're trying to make independent comparisons, this becomes really problematic, especially for exercise studies and those involving heat stress. That's not the end-all answer, though. You know, prescribing metabolic heat production, if you wanted to compare men and women, like I said, my recommendation would be to do so at a lower level of metabolic heat production that's below the pseudomotor threshold in women. Glenn Kenny's lab actually helped me develop the metabolic heat production studies. So his studies are less focused on the cardiovascular responses, but they did some really cool stuff with the metabolic heat production and prescribing it for exercise, and the thermoregulatory responses in men and women, and the effects of fitness level. So did Ollie J. So that's my data. Again, trying to close the gap, at least in exercise studies, and trying to include women in some of these studies involving, cardiovascular responses and heat stress. So hopefully I've given at least some something for people to go off of to maybe like redevelop their designs and consider some methodologies to include women. And I'll take questions now, dare I say.
All right, great. Thank you so much, Tori. And while I await kind of questions from the audience, I have a few things. As you were talking, it certainly brought back to mind a lot of the work that was done in my PhD lab at the Canadian Military Lab, what is now DRDC in Toronto. And one of them was kind of that classic study by the late Glenn Selkirk and Tom McClellan about fitness and heat tolerance, where they showed that the primary factor for heat tolerance and exercise tolerance was really fitness, and then it was also modified by body fat. So in your first study, you had body fat in essence controlled, and then you found a difference in kind of the fitness groups. And did you have kind of perceptual, I guess a few things. Did you have any perceptual data to show whether, even if they were at different temperatures, whether their RPE or their thermal comfort was different? And also, was there different in terms of their end core temperature at the end of exercise?
Okay, I'll start. Yes, there were massive differences in core temperature at the end of exercise. So when the high fit women are in the condition where they were performing exercise at the relative intensity, the high fit women had a much higher core temperature at the end of exercise because they're working at this higher absolute intensity. And there were no differences in core temperature at the end of exercise when we prescribed exercise using that fixed level of metabolic heat production. We did take RPE. I can tell you at a later date what it was, because I'm not sure right now. We didn't take thermal perception, but I did take RPE. Like I said, I would want to look before I state this with supreme confidence, but I believe RPE was higher in the low fit women, particularly during the metabolic heat production trial. So because like I said, 500 watts of metabolic heat production is a pretty high level of heat production, especially for women of a lower fitness level. So they're working at a work rate that's eliciting, they're probably working at, if we're speaking of relative intensity, like 75% of their VO2 max. So I can be pretty confident with that without looking at the data that, the low fit women had much higher RPEs than the high fit women in the in the fixed heat production trial. I would assume that, again, without looking at the data, RPE was very similar in the relative intensity as it should be. They're working at the same relative physiological intensity. So thermal strain though, or thermal perception, I'm not sure. We didn't take it, but that would have been something. That would have been a good inclusion. Yeah.
Okay. Thanks for that. And I guess another related question, I'm having all these flashbacks to my own PhD days, 20 plus years ago because of your talk. But the other question is, how might you think the data look and your findings and conclusions look if you're now talking more about an uncompensable heat stress situation of, again, I'm thinking of military wearing protective clothing or exercising in very, very humid environments? what would be your thoughts on that?
Well, the first one I would say for the last study, the sex differences study, looking at men and women, I think you would see, I think you would see in both groups, I think you would see these big differences in temperature, any temperature. Okay, so you would see increased everything. I think you would just see greater hyperthermia in general, certainly in uncompensable heat stress. And this would lead to, I think you would see greater magnitudes of drift, certainly, and greater decrements in VO2 max during uncompensable heat stress. I still think that the sex differences that we did see, although not statistically significant, I still think the differences, they would hold true, like in compensable heat stress, but I think the magnitudes of it would be much greater for both groups, if that makes sense.
Yep.
In uncompensable heat stress, but I still think the women would experience greater magnitudes of hyperthermia, thereby greater drift and decrements in VO2 max. Just both groups at a higher level.
Okay, great. Thanks for that. And again, if anyone has follow-up questions, please use the Q&A tool, but I'll go back to a kind of a question from the first part, which I know Gabe kind of typed an answer, but maybe if I can have both of you comment on it, which was really the work on that Gabe, you talked about, what a monophasic oral contraceptive and how that works, but what do we know about all the other types of contraceptives, of the biphasic, triphasic ones, etc. Has there been any work done on that? And again, what would be your guesses at how those different types of contraceptives may affect kind of any of the findings that we do know about?
Yeah, great question, Stephen. To my knowledge, I haven't seen, at least from my memory, anything on biphasic or triphasic. I know we have combined monophasic oral contraceptives, some research in that area, and the progestin-only mini pill, which doesn't have that ethinyl estradiol component. What I would, and this is just a guess, but what I would think for the biphasic and the triphasic, which for those of you who don't know, the monophasic is its one concentration of estrogen and progesterone for the combination pill throughout those 21 days, and then a placebo pill phase. Biphasic and triphasic, it's 2 different concentrations for biphasic. Triphasic is 3 different concentrations. And so what I would guess is that it would have the same effect, but to a greater or lesser degree, depending on what the concentration is. But I haven't seen anything that directly assessed biphasic or triphasic, just because it comes with those similar trade-offs, like trying to control for the menstrual cycle. It's easier because when they're in a certain pill concentration, but it's still a lot of multiple comparisons within the same woman. So definitely warranted. But I haven't seen anything that has directly assessed it.
Great, thank you. And Tori, again, I can't recall whether you mentioned it, but what was the kind of, were they all non-oral contraceptive users in your studies, or how did you control for those?
Oh, here we go. I included women that were taking oral contraceptives and women that weren't, with normal ovulatory cycles. And while this may not seem like the best practice, we have to understand that the idea was to make sure that you saw these big differences in core temperature between the 2 phases. And that doesn't change with like the difference between the 2 phases. You still see a difference between the follicular and the luteal phase in terms of core temperature, whether you're taking an oral contraceptive or you're not. Now, it was important. I did control for the type of pill, so I did make sure that we didn't include any women that were on the progestin mini pills, and they could only be taking monophasic pills. So that's, we did see, we didn't have enough data because it was a repeated measures design. So we had 7 subjects overall, but I think we had 3 women that were taking oral contraceptives, and they did have higher core temperatures in both phases. And this is common. We expected this. It would be interesting to look at, see if there were differences between those 2 groups of women in the follicular and luteal phase between groups. So women that were on oral contraceptives and women that had normal cycles in cardiovascular drift, thermoregulatory responses leading to drift, as well as that relationship to VO2 max. But did I answer your question? Sorry.
I think so. Yep. Yeah, no, it's always challenging. When you get in some senses, it's often challenging to get women to participate in studies to begin with, and then when you are starting to, kind of in a sense lump needing different categories or trying to segment them. I know we had a study looking at finger blood flow and CIVD, and we're trying to recruit only non-oral contraceptive users, and it was incredibly hard to recruit for that. So I mean, that is absolutely another challenge of research in this field, and but it is something that we still need to pursue. I guess, Chris, did you say you had a general question for both?
I did, yes. It's sort of been semi-answered, and there is no answer, so it's more just looking for your thoughts. But it's kind of going around the houses as to whether you compare the differences or whether you try and eliminate them. Seems to be kind of the recurring theme. So you either try and standardize everything to almost get rid of the sex difference, or you embrace the difference, which becomes potentially a messier study. So I guess from an applied point of view, you kind of need to embrace the difference maybe much more than from the mechanistic point of view. But I just wondering, from 2 people who are actively researching in the topic, where is your thoughts on that? Whether you try and remove all these differences or whether you embrace them?
I think at least in terms of like the menstrual cycle and kind of what Stephen was saying, in terms of the menstrual cycle and trying to control for differences that potentially are there with like different oral contraceptives and the different types that they're taking, I think those differences can be embraced within reason. So my study is a prime example of that. Like, we knew there would be higher core temperature if these women are taking exogenous hormones. This has been known in the research. A lot of what Nina has done that Gabe had referenced. We knew that was going to happen, but it didn't at least prevent us from answering our question. So I think differences like that could be embraced, but I guess, again, I'm just talking from my research, like the sex differences in pseudomotor function, if you're going to prescribe a metabolic heat production and at a high level, I don't think those differences could be embraced. I think that would make for a really messy results. Gabe, what do you think?
So I would agree. I think we almost have to embrace the differences, because if we try to control too much, we lose that external validity. And so if we're thinking about research from really trying to practically apply it, and we narrow it down, so we give every single one of our subjects a certain type of oral contraceptive and only test them in one phase to compare men versus women, we're losing out on some of that variability that really helps us to understand what's happening. It makes for a very controlled research study, but it's not really practically applicable. And so I agree that it does get messy. I can attest that it can get very, very messy very quickly, especially with menstrual cycle and trying to control that, like Tori mentioned. But I think if we're really trying to apply our research findings to an actual population, we have to embrace the changes and embrace the messiness, because it can't be perfect. We can't control everything. And I think that's one of the, it's a beauty of it, and also a frustration.
Yeah, Absolutely. And I guess related to that in terms of kind of applying the knowledge, it's and it was another question that you were answering during Tori's talk, Gabe, but it's really you know, the education component. I mean, talks like these, and again, in the general scientific literature, I think in general, scientists in our field are understanding the importance of these and these issues. But how do we translate it to, in this case, again, in military commanders, to give them, easy to understand kind of take home points of, this is why, for example, you may need to have different hydration strategies for your male and female soldiers, for example. And, do you know of any work that's being done kind of in terms of at the US military level to really provide that education?
The short answer to that is no. I'm not aware of any. That doesn't mean that it's not happening. You're referencing my answer to Allison, which is in the Q&A chat. Yep. She had a great question on how to try to educate commanders in the military, which is really important. And I think it's not the best solution, but almost to separate the recommendations that we're giving, even though, like I mentioned, we don't have enough data to make recommendations for women, having separate guidelines, even if they are very, very similar, helps to reinforce that for that population. How we get the general population to understand, it's a great question. I don't have a good answer for you. I think having talks like these and the way that VICE is doing it with posting them, I think that really helps the education component and makes it accessible. But translating our research and making it accessible, to a general population, I think is the first step.
Yeah, and whether it's military commanders, coaches, team managers, fitness professionals. Tori, do you have anything to add to that? I mean, how are you kind of working on kind of translating your data kind of in a sense beyond the academic circle, or what would you like to see in terms of working with whether it's coaches or trainers or et cetera?
I mean, developing some sort of it would be cool to develop some sort of algorithm that would, I suppose, that could be used in the field. So if something as simple as like a heart rate monitor, so heart rate, it could predict the drop in stroke volume, and this could relate to that decrement in VO2 max, which could be really important for workers, like heat stress workers that perform bouts of work, prolonged bouts of work in the heat. This is that they are at risk for experiencing perhaps severe magnitudes of drift. So knowing that they can't perform optimally, it could make for a safer workplace, as well as prevent heat injuries. I think that would be at least one way to make my stuff a little bit more practical. But right now it stays in the lab, unfortunately.
Well, I think this is kind of a good point to advertise that we have a talk coming up specifically about science communication. So this is definitely something that is kind of on our radar, and I think that's really important and kind of incumbent upon all of us as scientists to really translate our work, and because it is important work and it does need to get out in many senses beyond the kind of our academic circle. Chris or today, any kind of closing comments before I close out, or Gabe and Tori?
Nope. I was just wondering, 20 plus how many years ago were you doing your PhD, Stephen?
We'll not get into that. It was not this century or millennium, let's just say that. It's really shocking when I say things like that. But I will, again, share my screen. All right, so again, thank you both to Gabe and Tori for really insightful talks. And again, I think this is really a call to action for all of us in the scientific community to, certainly not ignore 50% of the population in our research. And even if it's messy, even if it's challenging, to really get into this field because of its importance. So coming up, we have a few more sessions to advertise. Again, they're going every other week, so not next Thursday, but 2 weeks from now. And the next one is probably one of topics that we definitely haven't covered before, but I think will be really fascinating. It's the managing travel and jet lag issues, especially in sports and occupational settings where we have athletes in North America, for example, traveling 3 time zones regularly to compete. And we also have many athletes traveling across continents for competing. So what are the ways in which we can kind of minimize the impairments from that, and how do we best kind of work with athletes and also, for example, soldiers and others who have to travel very quickly on short order. And then after that, on February 18th, we have another kind of new topic for us in our series, and it's all going to be about apnea and free diving. And we're going to have Anthony Bain and Alex Patrician, again, talking both about the physiology and also some of the actual kind of practicalities of free diving. And then on March 4th is the session that I was just mentioning, which is with the sports science writer, Alex Hutchinson, who I'm assuming almost all of you would know, who is a best-selling author and really a huge proponent of a lot of the work that we do. And the title of his talk is What I Wish Scientists Knew About Science Communication. So it's really going to be his take on what we as scientists need to do, how we can help individuals like him promote our work and make their lives easier, and to translate our work both through them and through ourselves. So again, hope that you will join us for those, and we will have today's session and also the student guide up in the next couple of days. So if you need to reach us, please feel free to do so. Again, the website is icee2021.com, and we'll also have the jet lag symposium up again, probably by tomorrow for registration. And you can also contact us at the email there. So thanks again to Tori and to Gabe for an excellent session. And thank you all for attending. Hope you have a great rest of your day.